Welcome to Heart Nurses, brought to you by the Preventive Cardiovascular Nurses Association. PCNA's mission is to promote nurses as leaders in cardiovascular disease prevention and management.
Welcome to today's episode, where we will take a deeper dive into treatment approaches for resistant hypertension. If you would like more background information about hypertension, including resistant hypertension, we encourage you to listen to our previous episode. Today, I am so grateful to have Maria Bonanni and Dr. Ruth-Alma Turkson-Ocran joining us, and I'm hoping, Maria, you could start us off by introducing yourself.
Sure. My name is Maria Bonanni, and I'm a nurse practitioner at the Hospital of the University of Pennsylvania, which is an AHA certified hypertension center. My practice primarily focuses on managing patients with resistant and difficult to control hypertension within our renal hypertension department here. Penn has worked actively in renal denervation trials for over a decade. I joined the team around 2019, so I've been working in renal denervation trials for about the last 5 years, and personally served as a sub-investigator for multiple RDN trials. I'm absolutely thrilled to participate in this podcast, particularly as we dive into renal denervation, which is an intervention that can really transform the landscape of hypertension management.
Thank you ever so much. Dr. Turkson-Ocran, could you please introduce yourself to our audience?
I am Ruth-Alma Turkson-Ocran. I'm a clinical investigator and instructor of medicine at Beth Israel Deaconess Medical Center and Harvard Medical School. I'm also a board-certified nurse practitioner, and I'm one of the nurse practitioners in our American Heart Association Certified Hypertension Clinic. I also do a lot of research in this area, particularly around hypertension prevention, management, social determinants of health, and also in the health equity space. It's such a pleasure to be on here talking about renal denervation today.
Well, let's begin talking about hypertension, in particular resistant hypertension, and the role of renal denervation in that particular diagnosis. Maria, could you start us off with that overview?
So I think to start, it's important to know that hypertension is a global health crisis. It affects about a third of the global population and half of the population in the U.S., equating to about 1 billion people worldwide. And despite its prevalence, blood pressure control rates remain low, with only about a fourth or 25% of all patients who have high blood pressure having controlled blood pressures. And alarmingly, there's studies that have been published that these rates of control are actually decreasing. Current treatment recommendations for patients who have hypertension are medications and lifestyle modifications. And we know that medication adherence is a major issue. And in some studies, non-adherence rates are up to 30 to 40% in patients who have hypertension. So given that our current approaches to hypertension are falling short, there's a pressing need for innovative strategies like renal denervation to improve patient outcomes. So the concept of renal denervation dates back to the early 1920s and 30s, when researchers observed the relationship between the renal nerves and blood pressure. At that time, surgical approaches such as sympathectomy, which involved actually removing the sympathetic nerves, was initially attempted to control hypertension. But these procedures, as you would expect, were invasive and associated with significant risk. So following these same principles, catheter-based renal denervation was invented at the beginning of the 21st century. Catheter-based renal denervation targets the same nerves around the renal arteries, and we've learned a lot more about the physiology of hypertension. So we know activation of the renal sympathetic nerves causes a host of pro-hypertensive effects, including renin secretion, increased water and sodium reuptake, and vasoconstriction. And these factors all increase blood volume, thus blood pressure, and drive further renal injury by promoting greater renal afferent firing to the central nervous system. And renal denervation through the ablation of the renal nerves aims to sever the connection between this essentially overactive sympathetic nervous system and the kidneys and thereby reducing blood pressure. Given that this ablation targets both afferent and efferent nerve fibers, renal denervation may also disrupt the afferent firing, thereby lowering global sympathetic activity. I think that's a long answer to your question. But I think given the reason to consider renal denervation is the high rates of hypertension, particularly uncontrolled hypertension in patients. And then this would be really another tool in our arsenal as providers to help reduce blood pressure and therefore reduce the risks of hypertension like strokes, heart attacks, kidney failure, heart failure.
What does the actual process of renal denervation look like?
Sure. So the patients get referred to, at least at Penn, our cardiology office, and we set them up to meet with one of our interventional cardiologists to plan for the procedure. The procedure takes place in the cath lab. So as I mentioned earlier, it's a procedure where they access the femoral artery in the groin, and then they thread a catheter up to the kidney arteries. During this time, the patient is awake and given conscious sedation. So patients are breathing on their own. They're not, anesthesia is not involved. And then depending on which catheter is used, the procedure is slightly different, but essentially the denervation occurs. There is some pain with the procedure itself. So patients are given pretty hefty doses of pain medication. I don't work in the cath lab, but that's what I'm told. And patients afterwards don't complain of that, don't remember the pain, but just as an FYI, there is some pain when that energy is given to the kidney arteries for the denervation. The patients are usually kept, after the procedure for a few hours. Again, the artery access will make sure that it's not bleeding, that it's healed. And then the patients most often go home the same day. I have heard that some patients, during the procedure, when you're given the medication, immediately post the procedure, blood pressures are much better. But most often that's because they're given, sedative medication. So I think patients come out and they think, oh, great, my blood pressure is 110/70. But you have to think about all the medications that they were given to kind of relax them. And again, so we think that the efficacy or the response in blood pressure does take several months after the initial procedure. But that's generally what the procedure looks like in most places.
So yes, renal denervation is actually a really promising approach for treating resistant hypertension. We had spoken about resistant hypertension in our in the previous episode or previous podcast, and resistant hypertension is essentially when someone is on at least 3 different medications, including a diuretic, just very briefly, but their blood pressures are still not at the target. So whether the target based on their medical history is, less than 120/80 or less than 130/80, you're still not getting to that target. And so we can consider renal denervation as a treatment that is complementary for the most part, or in some people, very few people, it can be an alternative to even medication. And these are a smaller subgroup for these people. They may be persons who have medication intolerances, or maybe just the pill burden that they have just to get to control is maybe very overwhelming to them. And so so again, can be complementary to antihypertensive medications in the quest for achieving blood pressure control among persons who have resistant or refractory hypertension. And renal denervation, there have been several, and I'll talk about it in just in detail, a little more detail in a little bit. But there have been several renal denervation single arm proof of concept studies that have shown that blood pressure significantly decreases with renal denervation. There have been some other studies that have also used some sham control trials that's using the more second generation of the newer renal denervation devices, for example, the radio frequency or ultrasound based devices. And these have also really shown really good evidence for lowering blood pressure with and without the use of concomitant antihypertensive medication. And I'm sure Maria will talk about the safety profile, which is really good too.
We're going to take a quick break, and we will be right back to discuss some specifics about the devices.
For more education, resources, and tools for your clinical practice, visit pcna.net. You'll find CE courses, patient handouts, and more, all free to access. Visit pcna.net.
We are back with our continued conversation about renal denervation as a treatment for resistant hypertension. Maria, could you please share a little bit more about the types of devices that are currently available?
Sure. There are two recently FDA-approved technologies in catheter-based renal denervation. One is a catheter that uses radiofrequency ablation, or it's Medtronic's Symplicity SPYRAL system, and the other is an ultrasound-based denervation through Recor's Paradise ultrasound system. Both technologies achieve the same goal, which is reducing sympathetic nerve activity in the renal arteries. As Ruth-Alma previously mentioned, the FDA approval is quite broad, and so it's actually going to be interesting to see how patients are chosen to receive renal denervation. The FDA indication, really, the language just states it's used to reduce blood pressure as an adjunctive treatment in patients with hypertension whom lifestyle modification and antihypertensive medications do not adequately control blood pressure. So, in a lot of these earlier trials, we excluded certain patients. And so I think this, really broad indication will allow a lot of patients to get treated potentially. So I think one of the things that we need to talk about is which patients are the right patients. And so, again, Ruth-Alma listed some of those. So I think clearly those who have uncontrolled hypertension, despite, guideline-driven therapies, patients who have medication intolerances. I'm sure you see lots of these patients where they have a list of 15 medicines that they can't that they can't take, and that really limits pharmacotherapy. Or those that patients, and you even mentioned this, patients that maybe just don't want to take medications or are very, their pill burden is unacceptable for them. So I think it does include a lot of different subsets of patients.
Dr. Turkson-Ocran, could you tell us just a little bit more? You alluded to earlier some of the studies that have been done about renal denervation. Could you expand on that just a little bit more and broaden our perspective in terms of how we studied this and how we got to these types of patients as potential individuals who might benefit from this?
Right. So I would say that the studies for renal denervation, or I guess renal denervation is not exactly new. There's been studies spanning at the very least a couple of decades for that. And so there are, we can talk about maybe the first generation devices that were radio frequency devices. Essentially, it's a unipolar electrode on a flexible catheter. Think about maybe like a 4 French catheter. And in the Symplicity trial, hypertension, the first trial that was in 2009, they used this device. And this essentially established that, or determined that, renal denervation was feasible, and in persons who had whose blood pressures were above target, you could actually see a drop in about 27 points. So about 27, when I say points, is millimeters of mercury. And so for the systolic blood pressure, and then about 17 points again for the diastolic blood pressure. That was in the intervention group control compared to the control group. And this drop in blood pressure, or the decrease in blood pressure, was still evident after about a year of the procedure. And so, of course, in the research world, we always want to kind of see that, okay, did this really work? And so there were some people, or some criteria that the Symplicity 1 trial did not exactly cover, and so they did a Symplicity 2 trial. And they also saw that blood pressure also decreased significantly, again, in here about 32 points for systolic blood pressure in people who had treatment-resistant essential hypertension here. And so, in the, to again, in order to address some of the shortcomings or the limitations in the Symplicity Hypertension 2 trial, they went ahead and did a Symplicity Hypertension 3 trial. And this was much larger. It was a multi-center, single blind, randomized sham control trial. However, this trial didn't really end up meeting its endpoint, because they didn't necessarily see a statistically significant drop in blood pressure with renal denervation. However, this also birthed another study, which is called the Dinner Hypertension, or a diagnostic evaluation of um, renal denervation for treatment of resistant hypertension. That's a mouthful. And this trial was a prospective randomized controlled trial, and actually gave us really encouraging results for renal denervation. And so again, in this trial, participants were randomized into, the renal denervation I guess, intervention, which was a catheter-based approach. And then you also had the control group, who essentially continued to receive their regular medication. It was called the standardized step care antihypertensive treatment group. And so they received so patients who had resistant hypertension also received the renal denervation alongside, the standardized stepped care antihypertensive treatment. And so persons in this particular group we saw a really significant decrease in systolic blood pressure after 6 months, because that was the outcome. What was your systolic blood pressure after 6 months? So we saw about a 13-point decrease in this particular group, compared to the group that was only receiving the standardized step care antihypertensive treatment. And so these results, again, were just really encouraging, and showing and essentially showed that renal denervation used alongside medication may essentially offer additional benefit for lowering blood pressure among persons who have resistant hypertension.
Thanks, Ruth-Alma. I think that's a great summary of kind of the data thus far. I just wanted to kind of pick out a few things to kind of focus on. So I think when I'm trying to think about counseling my patients on whether or not they should, consider renal denervation, clearly we haven't talked about, but you mentioned in your previous episode about secondary causes. So we really would want to make sure that we've evaluated everyone for secondary causes of hypertension, as well as rule out things like non-adherence, for example, or white coat hypertension. So we always like to make sure that we're, screening for these things. But so what I try to counsel my patients when I'm talking about renal denervation is that we do think that most patients respond. So when we look at all the trials across, we think about 70% of patients respond. So I do try to tell patients that, we think most likely that you'll respond. We can't guarantee it. I had a patient that came to me yesterday, actually, that told me my doctor told me I could be on half of the meds I am on today if I go for renal denervation. So I have to go as soon as possible. So I think setting expectations is super important. And then, like you mentioned, so when we think about the trials that have been published, we think that 6-month mark, where most of the trials endpoints are, we see about a 5 to 7 millimeter of mercury drop on average for patients. And then there are some longer studies that show duration of treatment and efficacy up to about 3 years. And we can even see more of a response in blood pressure. So a drop of, on average, around 18 millimeters of mercury over time. So really exciting. But again, I think it's really important that patients understand that it doesn't necessarily mean we're going to cure your hypertension. We're not going to necessarily reduce meds, right? So if patients are coming in with blood pressures of 150 on 4 meds, and now we can reduce it by, say, 20 millimeters of mercury, it's still now you're at goal, right? So I think that's really important, because I think there's a lot of information and misinformation out there. And so I think as providers, we need to make sure that we're providing that information to our patients and making this shared decision with them.
Right, exactly. And I absolutely love the fact that you're talking about, expectations. And I think sometimes people focus on the medications that people take, but I think maybe in this case, maybe some redirection to be looking at, okay, what are the figures? And so you may end up being on, your full dose, but then be a target with renal denervation. You may end up having to reduce your dose, but again, be a target, or you may end up not, getting off your medications. And in our clinic, we've seen, that range. And you're talking about, 70% of people actually get to have their blood pressures being a target. And so with the other 30% who don't end up being a target, and having to maybe decrease or alter their medications, our goal is, okay, your blood pressures need to be a target because of the long-term cardiovascular impact that it does afford. So, yeah.
Yeah, totally agree. And I'll just make the last point that, I think sometimes when you tell patients 5 to 7 millimeters of mercury, they kind of scoff at you, right? They're like, oh, this isn't a big deal. But, it is important, as you mentioned, for the cardiovascular risk. So we know that there's like population-based studies that show even a 5 millimeter of mercury drop in blood pressure can reduce cardiovascular outcomes by about 10%. And similarly, 10 millimeter mercury of drop, about a 20% reduce in all-cause mortality. So I think even though these numbers seem small, they can have a huge impact.
Exactly. I love that you mentioned that.
So we know that not every patient that comes to you might be a great candidate for renal denervation. How do you determine who is going to be a good candidate? What kind of qualities are you looking for? And also, are there any safety concerns related to this treatment?
Sure, I can jump in. I kind of mentioned some of the patients that kind of come to mind. Again, since the FDA indication is quite broad, the kind of 4 groups of patients that I think about, again, uncontrolled despite, guideline-based therapies, a pill burden that's unacceptable for patients, those with medication intolerances. When I didn't mention before is those with increased cardiovascular risk, maybe prioritizing them. And then when we think about safety, renal denervation procedures are generally considered safe with very low rates of complications, particularly when they're performed by experienced interventionalists in appropriate patients.
My next question for you is, what kind of workup is needed for prepping a patient for renal denervation?
So yeah, the things that we think about, as we mentioned earlier, and that was more thoroughly discussed in the previous episode, is to rule out secondary hypertension. So things like hyperaldosteronism, renal artery stenosis, fibromuscular dysplasia, pseudoresistance, non-adherence, white coat hypertension or white coat effect, obstructive sleep apnea. So I always like to rule out hyperaldosteronism with a renin activity level as well as an aldosterone level, both drawn through the labs, to rule out primary hyperaldosteronism, which is a secondary cause of hypertension. And send them for some type of renal imaging to look for renal artery stenosis, whether that be a renal Doppler if they're kind of normal or low risk, or if they're at high risk for renal artery stenosis, maybe send them for a CTA or MRA to rule out renal artery stenosis, get a sleep study potentially. And then I always like to confirm their out-of-office control, whether that be through the use of a 24-hour ambulatory blood pressure monitor or some home readings. That's kind of my first, step as far as evaluating patients for RDN.
So how does this look in clinical practice? Could you walk us through a couple of examples?
Sure. So there's a few patients that I've treated recently that I think would be kind of good general examples. So there's a patient that I follow who's 52, so young. He has a history of hypertension since his late teens and hyperlipidemia, as well as a history of CHF many years ago with a now recent normal echocardiogram. He has a strong family history of CAD, and I've been following him for many years. He's on 5 antihypertensive meds, including olmesartan, hydrochlorothiazide, a eplerenone, a clonidine patch, and a beta blocker, all at maximally tolerated doses. He doesn't tolerate calcium channel blockers. And so his pressures at home have always just been a smidge outside of where we'd like them to be. So maybe in the 140s, over 90s area. He's works in construction, so he's very active and moves around a lot. And he's very adherent with his medications, but as a young man, father, and busy worker, he has always wanted to have better controlled pressures to goal, as well as be on less medication. So we referred him. He was treated about 3 months ago, And I actually just saw him in clinic, and his blood pressures at home have been in the more of the 120s over 80s, and actually sent him for a 24-hour ambulatory cuff, where his blood pressures were actually more in the 120s over 70s. So I think that, he's doing really well. His blood pressures are coming down, and we're still early on in treatment. So I think the goal would be potentially reducing the number of his medications. But I think regardless of that, his blood pressures are definitely now at goal and at target. And being a 50-year-old man with family history of heart disease and other things, I think ultimately this is going to reduce his risk and set him up for better outcomes in the future. The other patient that's a little less straightforward, that always gives me anxiety and palpitations, is this young woman that I follow. She's 48. And when I first met her, she was actually on 8 antihypertensive medications, most at max doses, with blood pressures in the 180s, 200s. And so, has history of LVH. She's had retinal hemorrhages. She actually had some evidence of some mild primary hyperaldosteronism. And given that we did send her for adrenal vein sampling, which didn't lateralize, and so couldn't offer her any treatment there, but really have struggled for many years with this patient who has, clear end organ damage from her uncontrolled hypertension. And is very adherent. I've actually called her pharmacy many times to confirm adherence, has lost weight, has done all of the things, but again, blood pressure severely uncontrolled. She's not one of the patients that would have qualified for the earlier clinical trials, given her evidence of primary hyperaldosteronism. But because we really didn't have anything else to offer this young woman, we sent her for renal denervation, and she's been doing fantastic. So her blood pressures have been in the 140s over 80s, which again isn't goal, but for her is excellent and goal for me, and definitely a big win. So I think that's a patient. Again, I think, the one thing that I didn't mention earlier is that, we don't know which patients are the 70% of patients, right? So we've done lots of subgroup analyses of the patients that have been treated in trials, and we're not sure, is it someone's race, ethnicity, other groups, other diagnoses, gender. We don't know any of these. We've looked into these subgroups and haven't found the perfect patient. The one thing that we have seen in the clinical trials is that patients that start with higher blood pressures, if they respond more significantly, or the blood pressure drops can be greater in those types of patients. So I know the patient example isn't really like the standard patient, but it's a patient that I've been thinking about many times over the last few years of knowing her, and so it's been really rewarding to be able to offer her this opportunity.
This is absolutely, wonderful. I guess we, not with as many specifics as you have, but just to kind of add to what you have also said, we, again, I can just think about 2 patients that we did have. One was, both were male. One was in his early 50s. The other was in his mid 60s. Both of them underwent renal denervation. The younger one actually ended up coming off all their medications with blood pressures at target, so less, in the 120s, 80s range. However, the other one did not end up coming off their medication. I mean, we're still within the 6-month, I do believe, 6-month time, but we haven't yet seen any kind of decrease. Their blood pressures have decreased, yes, but they're still under their procedure levels of blood pressure medication. And so this just kind of goes back to our previous point about, you have 70, the 70 versus 30% of people who may end up still, the 30% still end up being on their medications, but you may still see drops in their blood pressures, but they may have to just end up staying on medication. But we're still in the process, and so just kind of looking forward to seeing what things may change. And on one hand, the question is it just because maybe the person who was older had just been in that state for a much longer time, and so was reversibility an issue. I feel like we need more studies in that area to be able to kind of get a better profile, like Maria was saying about, I guess, people who maybe this might be beneficial for versus not. But regardless, these are just really, really encouraging.
We often talk about the importance of team based care, and how does that apply in working with these particular patients?
So I guess I would start, and then I'll just let Maria um, continue. But when I guess healthcare in general should not be done in isolation. We do have experts in different areas here. I know our group personally, we do have in our hypertension clinic, we do have, pharmacists who we work with who also help with titrating, blood pressure medications, and again, nurse practitioners as well as physicians in our group. And I love, number one, working with a pharmacist because yeah, absolutely a wealth of knowledge in terms of, medication dosage, whether does this dose transfer to that dose. Um, but also just the insight from whether the physicians or the nurse practitioners, pharmacists, for example, in managing someone, getting them closer to target, and then if not, still in the working them up, making sure that they're properly worked up to rule out secondary hypertension, and then work up for renal denervation. But Maria, I'll let you just go more into details with that.
Yeah, no, I totally agree. Unfortunately, in our program, we don't have access to a pharmacist, and I'm very jealous of those who do because they're amazing from what I hear. And I do work with them in some other aspects of what I do, but I don't have them at my fingertips in our hypertension clinic. But no, I totally agree. I think, team-based care is really crucial for these patients. And I think particularly as centers adopt renal denervation, so, I've done a lot of work talking about setting up a hypertension program and about the AHA's hypertension kind of certification, how that can be really helpful and how can make your program strong and even be more marketable for patients that are around you geographically. But I think regardless of if you have the ability to, actually apply and achieve the AHA certification center, it's important to set up some type of hypertension center at your place of at your hospital system, because it's important that you identify the key players, who's going to be seeing these patients, managing these patients. So, a procedure is a procedure, but I think we need to figure out who's going to be seeing these patients before, making sure that they're good candidates, making sure that that secondary workup has been done, that the expectations have been set, do the procedure, and then who's going to be following them. So I think these are all really important things that need to be ironed out, as I'm sure a lot of health systems and providers and interventionalists want to, adopt this new therapy for patients. So I think team-based care is super important, and I think it's particularly important as we're adopting a new technology.
I have one more question for each of you, and that is, if you had one quick takeaway from today's conversation, what would it be? Dr. Turkson-Ocran, how about you?
Great. So I would say that there are options in the hypertension treatment, I guess, realm outside of lifestyle and medications that we can also look to in order to improve pressure control rates. And renal denervation is one of the options. Either, we had talked about very rarely alone, but most often with medication, we can work together with persons whose blood pressure trends may be considered on the resistant um, I guess, category, and then look into seeing whether or not renal denervation is an option. We have seen people completely not need blood pressure medications as a result of renal denervation, but we've also seen blood pressures get to target levels or levels considered control with both medication and renal denervation. Again, everyone is different. And people need to talk to their primary care clinician for what plan would be best for them based on their history. And what we have seen so far with the research and also anecdotally in clinic is that the results that we have seen or been seeing with renal denervation has certainly been encouraging.
Maria, how about you?
Sure. So renal denervation, presents a really exciting approach in hypertension management and has the potential to revolutionize how we address one of the world's most prevalent diseases. So its proven efficacy, safety, and durability are promising. However, it's crucial to recognize that the reduction in blood pressure may be modest and not all patients will respond equally. Thus, it's imperative for patients to maintain realistic expectations and for providers to engage in shared decision making. Additionally, ongoing patient follow-up is necessary to better understand which individuals benefit most from this intervention.
We are so grateful to you, both Maria Bonanni and Dr. Turkson-Ocran, for being with us today and sharing a little bit more about this process of renal denervation, which patients might be those that benefit most from this particular type of treatment. And so thank you so much for sharing your expertise with us. We'd also like to thank Medtronic for their support for this episode. You can find links to the resources and also to the trials that we discussed in this episode in the show notes. This is your host, Geraldine Warfield, and we will see you next time.
Thank you for listening to Heart Nurses. We invite you to visit pcna.net for clinical resources, continuing education, and much more.